Vamos a empezar con la conferencia del doctor Dion Morton. Él está en Londres, entonces nos hizo favor de grabarla. El doctor Dion Morton es director de uno de los 13 centros que allanan el camino para el futuro de la ciencia médica, la medicina personalizada. Nos referimos al Centro de Medicina Genómica de West Midlands, una asociación que trabaja para ayudar a implementar el innovador proyecto 100.000 genomas del National Health Services, el sistema sanitario de Reino Unido. Inició la expansión de la cartera de investigación clínica y el crecimiento de la colaboración internacional dentro de la comunidad colorectal europea. Sus iniciativas han provocado un gran aumento de pacientes reclutados para ensayos quirúrgicos y de ensayos quirúrgicos abiertos en el Reino Unido. Dirigió el Centro de Medicina Experimental del Cáncer de Birmingham, liderando el exitoso aumento de los reembolsos multimillonarios en 2012 y nuevamente en 2016. Es director de la Asociación de Interpretación Clínica de Pan Cancer Genomics England. Desde 2017 ha codirigido la recién creada Unidad de Investigación en Salud Global sobre Cirugía Global del National Institute for Health Research. Fue presidente del Comité de Investigación de la Sociedad Europea de Coloproctología, distinguido con el nombramiento oficial de la Orden del Imperio Británico por sus servicios a la innovación médica. Escuchen su conferencia, es verdaderamente interesante lo que plantea en torno al problema después de cómo se pueden combatir las infecciones, no necesariamente con antibiótico. Adelante, muchas gracias.
And specifically on the importance of surgical infections on reducing Hello, and thank you so much for inviting me to attend your meeting in Mexico. My name is Professor Dion Morton. I'm a surgeon from Birmingham, England. And it is my pleasure to speak to you today on the challenge of healthcare-acquired infections, and specifically on the importance of surgical infections on reducing multi-drug resistance and AMR. As a surgeon, my role in surgery encompasses leading the NIHR Global Surgery Unit. We have 7 hubs across the world, including one in Mexico, run by Dr. Antonio Ramos de la Medina in Veracruz. We also have hubs in sub-Saharan Africa and in India. These hubs run studies to reduce infection following surgery, and I'd like to talk to you about some of our work. You may feel that surgical site infection is not an important problem, but I can assure you it is. And it is not just important to surgeons, it is important to the whole community. There is a huge cost to surgical wound infections. They are the commonest complication after an operation, and they affect up to 1 in 5 operations after abdominal surgery. They incur significant morbidity and actually double the mortality after surgery. There is a huge cost to the patient and a cost to the hospital service. There are many interventions proposed to reduce surgical site infection, but unfortunately few of them have been properly evaluated. The important point is that most surgical wound infections, like this awful wound infection here, are preventable with the right measures. Our Global Surgery Unit has undertaken many studies across the world. Here is one that we completed in 2018. This study involved 12,500 patients from 66 countries. You can see that this encompassed patients from high, middle, and low income countries. You'll see that the wound infection rate was more common in low and middle income countries than in high income countries. You'll also notice that the incidence of drug-resistant infection, drug-resistant bacteria, was higher, was double in low-income countries as opposed to high-income countries. And we must remember that this has a huge impact on patients with twice the mortality, at least, associated with these infections. I would like to show you another study very briefly, carried out only last year, the Wolverine study. This study looked at wound infection rates after surgery across 40 countries in 100 hospitals. Nearly 2,000 patients were studied in this analysis. What we found is the wound infection rate was 16% in this cohort of patients. But these patients had far worse outcomes, with almost twice the hospital stay, with a high reoperation rate, high readmission rate, and a mortality of nearly 5%. Importantly, almost 1 in 4 of these wounds, 22.7% of the wounds, were not healed at 30 days. This means that these infections were being carried into the community and their treatment was being carried into the community. So with 1 in 4 wounds being unhealed after discharge from hospital, that leads to the uncontrolled use of antibiotics. And we know that the use of broad spectrum agents in the community has almost doubled in recent years. This is part of the rising incidence of antimicrobial resistance, of AMR, and surgery has an important role to play. AMR is in the top 10 world health threats, and multi-drug resistance in wound infection results in long courses of antibiotics. And as I've shown, this continues after discharge from hospital. And this continued course of antibiotics is uncontrolled and unmonitored. Of course, these events are life-threatening for patients following surgery and very resource-intensive. So what is the challenge for surgeons? The challenge is to prevent these infections, but also reduce the use of antibiotics. And these two factors almost seem in competition with each other. The other problem is, the other challenge is that wound infection is a complex event. It's not down to a single issue. There are multiple issues that influence surgical site infection. There are patient factors, disease factors, surgery factors, and post-surgery treatment factors, as we've just discussed. The solution is to look at preventing surgical site infection in the first place, and ideally to use non-antimicrobial agents to reduce these infection rates and to control these infections within the hospital before patients are discharged to the community. I'd like to spend the next few minutes talking to you about some of the studies we've done to bring this about. Here is a study where we introduced 3 different agents to reduce surgical site infection. The study is called Rossini 2. We used alcoholic chlorhexidine before surgery to reduce skin contamination. We used impregnated adhesive drapes before the surgery started to try and maintain the cleanliness of the skin. And at the end of the operation, we inserted gentamicin collagen sponge as an in-hospital single intervention. And these interventions were tested together and separately, so that the patients were randomized into 8 different arms, where in one arm they had all 3 interventions, and in one arm they had no interventions, and they had every combination of the intervention in between. And this study was then re-evaluated at the end of a pilot phase, and those interventions that were obviously not working were dropped, and then the study continued for a further phase, and then further arms were dropped. And this cycle has been completed. and actually the results are just about to be published from this study. Our challenge is to look at whether we can use this model across the world. And in a new study called Marlin, we are now looking at multi-arm, multi-site randomized trial, looking at to prevent surgical site infection across the world. And we are doing this study across 7 different countries using our 7 hubs. The challenge here we have is that, of course, there is variable availability of these interventions, and we have to distribute them across the world. There are also ethical considerations that need to be met in different countries that are not always the same. And we have to also measure variable current practice and clinician equipoise across the world. But despite this, we are launching this study. And the Marlin study looks like this. We are actually introducing 3 different interventions, 1 before surgery, 1 during surgery, and 1 after surgery. Before surgery, we are randomizing patients between chlorhexidine preoperative washing versus control. During surgery, we are using a chemical irrigant to reduce bacterial contamination in the wound versus a control of standard practice. And finally, after surgery, we are using an active wound dressing, which is an antibacterial wound dressing called Leukomed versus a control standard wound dressing. And we are measuring this in 7 different countries. This study is about to be launched. One of the things that you might have noticed is that we have to change behavior in operating theatres if we're really going to improve outcomes for these patients. Here in the Cheetah trial, we undertook a trial of asking surgeons and theatre staff to change their gloves and to use clean instruments before closing the wound after an operation. This is a simple intervention. It is very cheap to implement, but it requires a change in behaviour and practice in theatres that we wanted to implement. A huge team from across the world undertook this study. 87 hospitals from 7 countries took part, and over 13,000 patients were randomised into this study. The study recruited over 18 months, and at its peak, we were randomizing 1,000 patients a month into this trial. Very fast, very powerful way of getting high quality data. I would also like to just share with you the different hospitals. In about 1/3 of these hospitals, they were local district hospitals, not big hospitals, but small hospitals. And in about 2/3 of the hospitals, they were big centres, tertiary centres. So we are testing this change in practice, not just in the teaching hospitals, but also in the local hospitals. We're testing this intervention in emergency as well as elective patients, and we measured the standard practice in these hospitals, whether they undertook the WHO safety checklist, whether pulse oximetry was used, whether prophylactic antibiotics were used, and whether they undertook hair removal, for example. I'm delighted to say that this simple intervention was successful, and it prevented 1 in 6 wound infections from occurring in these patients across the world. And this was a very powerful finding in that every minimization factor and every variable was tested, and it still held true, preventing about 1 in 6 infections. We also undertook a health economic analysis of this study, the Cheetah study, and this showed that actually this intervention was more effective and was of comparable price to not undertaking. So this was cost effective as an intervention. It is now being taken up by governments across the world. There is clearly a need for us to speed up and accelerate learning around how to improve wound infection rates across the world. And in a new study that is about to be launched at the end of this year, Rossini platform, we're actually going to undertake these studies simultaneously in multiple different types of operations. I'll just show you how we do this. In the Rossini platform study, we are going to expand the Rossini 2 study across the whole body. So there are going to be multiple parallel studies being undertaken in different types of operations. This will allow learning across different surgical specialties and allow us to more rapidly implement improvement in practice. The study design looks like this. It looks very busy, but there is basically a different study for breast surgery, for groin vascular surgery, for heart surgery, for neurosurgery, for leg amputations, and for chest surgery. And each of those different studies will also have different interventions, and each of the studies have 3 interventions that they have chosen for their patients. So these interventions are being tested on different patients and in different combinations. And this actually allows us to actually learn from one study, and if it's working, we can test it in a different population of patients in a parallel study. So we can more rapidly implement this change in practice and more rapidly learn to improve how to improve outcomes for our patients. We think this is a very exciting venture that we are hoping to take across the world. You might ask, actually, studies are not enough. How do we actually change behavior and practice? And in our studies, we are now undertaking educational platforms. So the learning from these trials will be transferred into education for surgeons, for theatre staff, and actually for patients and community workers, so we better manage and better prevent wound infections. This can transform practice very quickly across the world. So finally, we think the future is bright. We think we can reduce surgical site infection dramatically across the world by providing high quality, rapid evidence in these trials. We can evaluate the implementation of this new practice through educational platforms taken simultaneously across the world and implement behavior change. And finally, we are now working with community workers across the world to identify wound infection early and implement rapid change in practice. I'd just like to thank all of our co-workers from across the world. We meet up every year in different countries to look at the new trials we're going to undertake and what studies need to be done. And this year we had the pleasure of meeting in Cancun in Mexico, led by our Mexican team from Veracruz, and we had a very successful meeting. I'd like to thank you for your attention, and I hope you enjoy the rest of this meeting. Thank you.